Get back to the States?
Sunday. Yeah.
That was the nicest day in a long time.
I thought yesterday was awfully nice, too. I mean, it cooked outside both days, on the grill. It was nice.
That's pretty good.
A little chilly.
I was working in Redmond and then fighting the traffic back.
I took a vacation day yesterday.
Are the Mariners doing well? That people are going to the games?
Who knows?
They're almost at 500.
Mm-hmm.
I think they've had a good run. I don't follow them. I don't really follow baseball until
I don't follow it really.
Until the end of the year. Finally, the World Series gets exciting.
Yeah.
Have you been going over to Boston some?
Just once. I'm going to go back again in early June.
Mm-hmm.
Baby will be 2 months, the
Nice.
15th. It's a long trip.
It is. At least there's a direct trip, though.
Yeah. We're going to go in June and then go over to our house in Hawaii. It's interesting. I didn't.
From Boston?
No. For a couple of
That's
days.
a long
And
trip.
Next trip is Hawaii. I forgot to reserve my own house, so when we had tickets, the agents rented the house, so I could squeeze in 3 nights in my own house, and then I have to find someplace else and pay for it to stay.
How about your condo?
Those also booked.
Life's hard.
It's stupid, yeah.
Yeah,
I mean, it's
life's
good for
very
business.
difficult.
It's nice to be booked.
Yeah.
Mm-hmm. That seems silly.
But it's true. We got a place up in Alaska that we rent out all the time. And it's the same thing. I say I want a weekend, and the agent goes,
Yeah, well, you have to think ahead.
yeah, well,
Right.
thank you.
Yeah.
Figure that one out. Think ahead. Do you need anything, Dr. Weiss?
I'm good. Thank you.
The
Yeah.
clinic? I think so.
I think we're good.
Yeah. Cliff is good. We always make sure
That's
that.
great. When we use our compassionate use,
Yeah.
he's usually right on top of it. And
Yeah, he is.
on capture.
Yeah.
Which is great.
And if I'm a little late getting in there, he calls me. He does. He says, I'm down to 1 vial.
Yeah.
Dr. Weiss is back.
Thank you for keeping in touch with him.
Oh, yeah. He's a good guy.
Yeah, definitely.
You have good weather on trip?
We did, except for one day, our last day in Spain. So we were supposed to play another golf course, but it wasn't like one of the really great ones. So we just took the day and sort of did the gym and spa and shipped our clubs back a day early, which was good.
Oh, you shipped your own clubs over?
We the club was very helpful. One of the guy whose birthday it was researched it. And there's a company called Shipping Sticks that will ship your clubs anywhere in the world, essentially. They use DHL. But the club, once we said, okay, 6 people or 5 people want to ship, the club took it from there and they worked with DHL, got it the cost, and everyone just shipped it back to the golf club. So it was like 1 pickup and 1 drop off, so that was really good. Otherwise, shipping them, dragging them around Sicily and stuff.
I don't normally see like a parking meter person out there, but I noticed your parking stickers on the driver's side, and you want to put it on the passenger side. If you're parallel parked, they'll still give you a ticket. I don't know if you want to move that or not.
They're too lazy to look on both sides of the car?
Yes.
They're sticklers like that.
Thank you.
Yeah.
What side should it be on? I got to make sure I do.
I'm the
on the
curbside.
one that they are
Whatever the
walking on
curbside.
the curbside?
Curbside? Yeah, curbside. Yeah.
That makes sense.
I've gotten a ticket for that when I was first new to Seattle and I had no idea. And I was like, but I bought it. Oh,
Nope.
they don't care.
Nope.
They don't
They
care.
walk by.
Really? You got ticketed?
Yeah,
for
I
having
did.
it on the wrong window?
Yep.
It's not cheap.
No. It was expensive.
Yeah.
I was not happy.
I put mine on the right side.
Yeah.
Yeah, curbside. Always keep it on the
I
curbside.
learned my lesson, to say the least.
So your next trips are Boston and Hawaii, huh?
Boston and Kauai, next month.
Is Galen working?
Yeah. She's a machine.
At CLU?
I think she's just at the UW now.
In the nursing program.
a PhD, RN, head of, I don't know what.
Yeah. I thought she was actually running the program at one time. Wasn't she running the program?
She was running the simulation lab.
Okay.
And trained people on mechanical dummies.
Mm-hmm.
She doesn't do that anymore, but she's teaching seniors.
Okay.
Actually working.
Good.
Plus runs our real estate that we
Yeah, I know. Yeah. You made some good investments, sir.
Yeah, she did, really. She's got the brains to do it.
Yeah. And raise chickens.
We have a couple of them for tomato.
Are you anywhere near Williams? Paul Williams?
Yeah, a couple of miles apart.
Okay.
We're on the Puget Sound side.
Oh.
It's all
okay.
Puget Sound.
Yeah, and he's on the other side.
He's east when you
Yeah.
enter the island.
Yeah.
We're going to have a retirement party for Lori Jo. You know, she's retiring.
I thought she was retired because I saw Katie there.
Well, Katie, they're overlapping, so that Katie does her job.
Name up on it, looked out of place.
Yeah, it's a bit
I
of
think this is her last
a
month.
long hammer about the events that went on.
So they're just overlapping. Is that it?
Yeah.
Yeah.
Does Lori Jo finish at the end of this month? The retirement party's May 29th.
My understanding is mid-June.
Mid-June.
Yeah.
You know, her husband has a very interesting job too. He does repair work on Boeing craft. He travels around the world.
I know he travels. a
Yeah,
lot.
it's
No.
incredible. You know, he's been shot at, and oh yeah, you know they'll land like a 37 or a 757 or here and there, you know, somewhere in the Congo or whatever, and break the landing gear.
Right.
And he's the guy that's got to go in and repair it all.
It's an incentive to get it done quick, anyway.
Not well, just quick. Get it off the ground.
But I think he's retiring.
Yes,
Yeah, I think they're
Yeah.
both retired.
I
Yeah,
think,
exactly.
that was a planned.
Yeah.
Young retiree,
Yeah,
by my standards.
I'm sure he's done well. You know, Boeing stock is great right now. So,
Is it? Yeah.
Yeah, I think they're doing well. And
You see, the Chinese built their first airplane. They're starting an industry, and it's almost, if you look at dimensions and everything,
it's identical.
it's identical, yeah, to the 737, some
Yeah.
iteration of the 737.
Yeah, I think
And
everyone
Airbus.
knew that was happening, right?
Yeah, you're
when
right.
they started working and building parts in China, I mean,
They'd steal the
that,
technology.
yeah, that was a known.
Yeah.
Yeah.
I guess
Absolutely.
they did the conscious decision they're going to steal it one way or another. We might as well get
Might
10
as well
years
try to make some money out of it.
This,
Yeah.
this is about the third plane that they put out, though. They put out one that looked like 707 that flew once or twice or something.
Oh, yeah.
It's been a long learning curve for them.
But
it's
they're
easier
also
learn
supposed
when
to have a major, remember the automobile manufacturers are concerned that there'd be a lot of Chinese imports, and then they'd have a major automobile industry, and that hasn't taken off either. South Koreans are doing great with automobiles.
Yeah.
Have you seen, I know you're a car guy, have you seen that Chevy Bolt at all?
I haven't seen it in person, but it's technologically, it's got the same range as Tesla
Even a little longer.
Yeah,
It's
yeah,
236 miles.
in a $30,000 vehicle.
Yeah.
Yeah, but it's a smaller car too.
Much smaller,
its
much
purpose is
smaller.
different, but still.
Yeah.
No,
It's a
I'm
big
with you.
breakthrough.
If you just stay in the city.
And I think they're beating the Tesla 3 to the market by about a year.
Yeah.
Yeah.
I mean, Tesla has a cachet in its name now, and their stock, it's amazing.
Their stock is unbelievable.
Yeah,
And even if they don't build cars, just building these battery
plant.
You're right. But have they made a profit yet?
No.
No, I think it's all government
Yeah.
subsidized, right? Yeah. No, I know. I'm staying away from it for right now.
So all of those that they had an auction about getting a place in line to get the whatever
To
that
get
third
the-
model is.
Yeah.
Right.
They sold so many of them.
Yeah, people put
They
down
do.
payments.
I think
Oh, yeah.
100,000 people put
Yeah,
down.
and,
Yeah.
and they're only putting
Probably
down $75,000
$50,000
a year.
$25,000.
So the best thing you can say is that you might get one in 5 years.
No, you're right.
Yeah, so the Bolt might be
Good morning.
quicker deal if you want the commuter car.
No, it's more than
Yeah.
a 200-mile range. It's almost a fraction of a vehicle.
I can't figure
So-
out traffic the last 3
If
weeks.
you want to use it as a highway
It's been like
car,
only
they put in
35 minutes from Summer, so I've been this way
superchargers
for
up and down
20
the
years.
coast
So.
and across country. So it takes about a half an hour to recharge your car, as opposed to stopping in a gas station and refilling your tank in 5 minutes.
Yeah, the recommendation, at least with the Teslas, has been that you do a half charge. It takes 15 minutes.
And you just have to have charging stations frequently enough.
And they're building more and more, but they're not. They don't have the whole country taken care of.
You know, we've had 100 years to build gas stations.
Well, yeah, that's something they can sell. Electrons are a little too cheap.
And then Dr. Altman has a car that
No,
gets 14
I'm sort
miles
of.
to the
I
gallon.
started this conversation knowing Len loves cars, asking him about the Chevy Bolt. That's, sort of out in California, just starting to show up. I think in Washington.
Seen a few of them.
You have a neighbor at the Whistler, and he has a friend with a Tesla, and he says the charging station heats up his garage unless he's got mold growing all over the inside of his garage. Because he has one of the fast chargers in his house.
Yeah, I
And he
have a
said that
couple of friends who have that. I haven't asked them, or they haven't mentioned that.
So he just said that wasn't anything they warned him about. So he's been totally shocked. He's had all this mold growing in his garage. They're sure fast.
And he,
Yeah,
he
they are.
thinks it's part of the charger.
Yeah, he says that when the car's charging, the garage will be 90 and 100 degrees.
Kennedy, I've never actually driven.
I mean, yeah.
Yeah.
So old neighbor, both
Big fan.
Maybe see your car.
It's just like
Make your car feel better.
there's no delay.
I don't know.
In the wintertime, that's for sure.
It's just I can buy 3 Subarus.
I think you're getting an electric car, and so
I
I'm
think it'd
trying
be
to.
totally cool to have one.
I think the Bolt will be
That thing,
fine.
yeah.
I mean, I would get the Tesla.
240.
I don't want to spend
Yeah, it's still
what
less.
the
If you're trying to-
sedan or the X cost, but I think I could get probably a Bolt or have
You know, Dr.
They're just selling it in limited markets.
I think we were in Sun Valley a couple years ago
California market
for
first,
Lima
just to
Mountain.
meet their requirements for.
And he made it with like 2 minutes left.
Yeah, but
In his car.
Yeah, because he had to go through the mountains and everything else. There were no charging stations.
Yeah, I guess that's true. You stop in Boise, and that's probably good.
Yeah.
haven't
And I remember
looked
him
either,
saying,
so I think
I was in the
maybe
red,
this weekend I'll
didn't
try
think I was going to
out
make it,
there
and he finally
see
made
if
it.
they have it.
And then Sun Valley,
Probably
apparently they had a charging
list of
station.
people.
So,
It is at least an advantage of the, what is it, the Ford one. That is correct.
we're talking about the Chevy, is it Chevy, right?
Chevy
Bolt's
Bolt.
just a straightforward electric.
It is,
I think a Ford
Is
has a
cross-
motor.
Yeah, they have a lot
Gas
of.
to charge.
They have the Chevy Volt, which sort of does like 23 miles on your electric, and then switches over to gas. They have a couple of those out there.
Yeah.
I was just amazed how fast they're. I rode in it.
Oh yeah, very instant acceleration. They are.
One of our daughters got the Model X that Good morning. I'm sorry.
Where are you guys?
She's trying to keep up with me going on the freeway, and she was gone in like 2 seconds.
One place which was really nice
Quite
was
amazing.
Wow.
a little bit more than I wanted to pay.
The problem is you can't hear it. I've stepped behind one every now and then, and it's like they're moving, and I'm like, whoa.
When you're standing in a crosswalk and you turn around, this car's on your butt.
Exactly.
Really
Good. I understand what they're talking about. At least there's beats on your backgrounds or something.
I mean, it was
Now-
I mean, it
The
was less
technology's
expensive
got
than
to
the
come
other one.
until they can make a race car that wins like NASCAR 500 or 8,500. I'm thinking about early 70s. If they get one of them in the 500 miles,
Yeah, but they'll blow them out. Remember they had
work on the air and take it. Be efficient. Yeah.
I've never gone to one, but I'm going to go.
Yes, they're good. How about that?
There might be a little bit of fees that don't have. I'm not starting to.
It went from every week to once a year.
Yeah.
What's the web? What is the web for?
You go online. You're online.
Yeah.
Oh, I don't know. Gets me up and going in the morning. So I can run around.
So I should be commissioned.
Oh, there you go.
It's like the volume first time. Yes.
I'm going to Maine for a week or 10 days.
You still working full time, Mike? Are you part time? What are you doing?
I guess I'm working part-time, but considered full-time in my mind.
That's a good way to phrase it.
How are things?
Good. Yeah, with you.
Same old. That's why we are much recently.
Delta Yield Club.
This is early June. See our grandkid again in a couple of days in Hawaii.
We're kind of busy here taking care of us all the time. You can't leave. That's the problem. You can't die.
I'm dying. You know something I don't.
You will die. I do know that.
No predictions when.
No, the way you're going, I think you're going to have to live all of
And
this.
if you look, it's like Frank Rocket. And I'm just like, no. She can just, you have an opening, so I'm moving her over. She's just kind of from that refill. I'm sure she's very
I know.
especially if
Sometimes the front desk, definitely. I mean, to be fair, maybe there wasn't. So it's rarely urgent.
I don't know so.
Yeah, now I'm going to do another college show.
Yeah.
Exactly.
The pointer is. I know the pointer's in the right.
So last fork, we're going to have to share it. Oh, here it is.
Everybody throws up on me. I already.
They're in a package.
I can wash it for you.
That's right. F5. Oh, you're fine. 4 hours.
You see my text about the power washer?
Yeah, he said he'd get it back.
Did you use it?
Yeah.
Power wash next week. Oh, my aggregate rock driveway. I did about 12 hours last 2 weekends. It's 30 is messy. My driveway gets so much moss on it out there. Yeah, but why? Let them have all the fun.
You gotta put on your boots.
Oh, you know, I didn't get the black on. You're right, I could, but I can't afford it. That's the difference. So I'm stupid enough that I actually enjoy it. I know, I'm sick. Yard work is my future. Retirement.
Did you write one of the discs to do it, or did you just
You know what?
your head?
The discs work great on cement, but they don't on asphalt. And that, gets down deep. This is an old driveway too, so it gets down to cracks. And
Those discs are pretty nice.
Oh, on cement. They haven't. You know what? I shouldn't say that. I haven't tried on my aggregate rock. I do have one. I'll have to try it this time.
Most of the time, no. When we used to pay for this service years ago with you go your system. You don't, but one time somebody asked me,
I got like a large for California, Washington.
I were about 20 people. A lot in Oregon was because I don't know if they have their journal club anymore. They used to do quarterly sessions. But a lot of them dialed in, like I shot, and most of the people in Eastern Washington.
I think some of our fellows are.
We have fellows in California and LA in Texas. In the beginning of your David Hagen used to listen to LG. He wants to come back. I think it all has to do with
Mike.
Very nice. Guy in Bellevue that's doing humidity sensitization.
That's awesome.
Only one. Well, Mary knows about it. Angie.
sometimes when I call in on the phone, sometimes when I don't come in and I'm like, I can hear these conversations like really well. So, I don't know.
Much less.
I'll talk to you out there.
Yeah, that's true. And I understand.
You know what? It's funny you're here.
You just open the practice around.
Like that southern note, people actually would be smart because there's
Got it all through there.
he's there.
One of my patients said they didn't have to wait. I mean, that is the job done. They can get it through the help.
They stay on and then have to go back.
The only thing with
They don't do any other antibiotic.
who went to the meeting and saw him?
Is there like a pharmacy right there?
In Jerusalem?
Is it like a hospital? Is it like an ambulatory center?
So they have a great store.
What's the word of the day?
Allergen.
Allergy?
Allergen.
That was gonna be everything else formulated. So that's why.
I didn't hear the feedback.
I agree with
Let's go ahead and get started. Just a couple of quick announcements before we start. The year-end dinner, we have an RSVP, is in 2 weeks now, I think the 23rd. And I have to meet with the caterer and get a fairly accurate head count. So if you intend to come, RSVP to me or Tina at Northwest Asthma and Allergy. It's in the adjacent building. I think that's the 850 building that we used to use in the past. I'll let you go ahead, Mike, and make an announcement.
All right, just a brief announcement to remind everyone that tomorrow night's the person dinner. This year, we've saved up enough funds. It's actually going to be at Osteria Rigoletto, which is about 6 or so blocks east of here, starting at 6:30. Full disclosure, many of you know that about 8 or 9 months ago, I asked Tom Fleischer to come out and talk to us. And the short story is, about 3 weeks ago, there was a serious medical issue in the family, and he said, I've got to let this go. And ironically, he was going to give the talk that Marcus Boos gave a couple weeks ago to us at Journal Club. In other words, the cutaneous signs of immunodeficiency. And so I was thinking about, well, how can we make this work? And thankfully, Marcus has agreed to sort of step in. And he's going to talk a little bit about what we interface with derm a lot more with, and that's atopic dermatitis. Sort of clinical mimics and some unique, I think, clinical pearls related to other things we might see associated with the diseases we all treat. So tomorrow night at 6:30, Osteria Rigoletto.
Okay, last thing, just introduce Mike Weiss, who's just back from a lovely vacation in Spain and Italy. This topic, at least every day, perplexes me. What to do essentially with people who have positive skin tests, particularly with food, and yet are tolerant of eating that food. And I'm hoping to learn the answer.
Well, thanks for coming and thanks for getting up and being on your computers, those who were there. So I got this topic assigned to me by Len, and I looked at it, and then I started doing some research. Usually I'll sort of whisper in Len's ear and say, hey, why don't I give this talk, or he'll give me one of numerous talks over the last 30 years, and it all seemed to make sense. But this year I had a number of back and forth conversations with Len by email and verbally saying, there's no real science in terms of why this happens. It just happens. Stuff happens. And I could say that's the end of the talk. But instead, I thought it would be very useful, hopefully, to spend the next 45, 50 minutes talking about what do we do in this sort of difficult situation where we have diagnostic tests that say one thing, but really clinically it may not be really what's going on. So how do you deal with positive skin or in vitro tests for mainly food allergies in people, mainly kids, but some adults who really don't have a food allergy? So before we continue, I just wanted to, I know we can't get a show of hands on people who are listening, but so we have a limited number of allergists here in the room, but just a show of hands, who does not in their clinical practice do oral food challenges? Good. So if you do oral food challenges in the clinical setting, who does on average one a month, would you say? Okay. Okay. Who does 2 to 3 a month? Okay. Who does 1 or more a week? Good. So hopefully more people will go after this talk to the higher end of that, because it's really necessary. There are some days I'll do 2 or 3 a day. I'll do 1 in the morning and 1 in the afternoon. Sometimes if it's a sibling, they say, I got to come in at the same time, so we'll do 2 siblings in the morning and a different one in the afternoon, but you do need a lot of time to do these. So we're going to discuss today only IgE-mediated food issues. So all the ones on top that you're well aware of, we're not going to be discussing at all. So we're going to talk about how to help patients, knowing that there are many of our patients who have false positive tests for IgE-mediated food disease. And again, we know there's a problem in that many people in the United States feel that they're allergic to food. So if you ask them in questionnaires and surveys, 30% of the population says, yeah, I have a food allergy. But when you utilize oral food challenges, the rates are significantly lower, anywhere between 4 to 8% of the pediatric and 1 to 6% of the adult population, probably closer to 1%. So the discrepancy really highlights the importance of diagnosing food allergy in the proper context of the history and using your diagnostic testing to help. There are false positive tests that are, unfortunately very common with foods, and rates have been as high as 40 to 50%. This can lead to overinterpretation, misdiagnosis, unnecessary costs, healthcare costs, unnecessary dietary elimination, and in many families, and many of you have these folks, extreme anxiety within the family context. So modalities that are recommended by expert panel in helping to diagnose food allergy include, and the ones that I've put in yellow I think are the most important, and that is clearly the medical history is so critical in this diagnosis. Physical exam, skin tests, serologic tests can be helpful. Elimination and what I would also put hyphen reintroduction of foods can be extremely helpful. And then probably the most important is oral food challenges to really ascertain, is this patient just sensitized or do they have a true food allergy? Modalities that are not recommended by expert panel, intradermal skin tests for foods are way, way, way too many false positives. No need to do total serum IgE measurements. Atopic patch tests have not been found to be useful. And then any number of these non-standardized tests that some practitioners seem to rely on and are pushed by certain companies that sell these tests. I gave a talk recently, and there was a couple of naturopaths in the audience, and they told me that now U.S. Biotech is pushing food IgA testing. So they weren't happy enough with IgG. Now they're pushing IgA-specific food tests. And this poor naturopath says, I'm just totally confused. I don't know what test to order for my patients.
What not to order.
Okay, so common foods that cause these issues that you'll be dealing with are cow milk, wheat, egg, soy, peanut, tree nuts, fish, and shellfish. And these will account for greater than 90% of all the IgE-mediated food reactions. They can vary by age, the local diet, and other factors. And certainly we know in children, eggs, dairy, peanuts, and tree nuts predominate. Slightly different in adults, where peanuts, tree nuts, and seafood allergies are more common. Certain seeds, including sesame and mustard, are common food allergy triggers in some countries. And as we've all seen doing this for many years, almost any food in the right person, in the right genetic host, can cause a true food allergy. If you look in North America, the rates for children and adults, again, milk, eggs, peanuts, tree nuts predominate in kids. Peanuts and tree nuts and shellfish sort of tend to predominate in adults, and then you have the overall rates down below, 5% and 3 to 4% in infants and adults, respectively. So establishing a diagnosis of an IG-mediated allergy. Initially, most of us would start with a skin test. It does provide a rapid method to screen patients for sensitivity to specific foods. And typically, it would be considered positive with a wheal of 3 millimeters larger than the negative saline control, indicating that the possibility the patient has symptoms relative to the specific food. An extremely strong skin test size is 8 to 10 millimeters, indicate a greater likelihood of true clinical reactivity in younger kids, at least. That may not hold up in older kids, actually, and adults. Negative skin responses are extremely useful in that they confirm the absence of IG-mediated reactivity. And in general, across the board of pretty much all the tests have a negative predictive probability of greater than 95%, which is pretty good. Again, skin tests, positive responses only suggest the presence of clinical food allergy and don't confirm that diagnosis. A positive skin test response is often considered confirmatory when it's combined with a very recent and clear-cut history of food-induced allergic reactions to the food in question. So that if the patient comes in with a very strong history and then the skin test is positive, that may be all that you need to do. In infants less than 2 years of age, a skin test to milk, egg, peanuts with wheal diameters of 8 millimeters or larger with a history are definitely predictive highly of true food reactivity. So history, it's sort of like real estate, location is the most important factor when determining whether a food allergy really is present. So you want to have the historical elements that we all know to appreciate for a true acute allergic reaction, with the timing of the symptoms, the onset duration, the characterization of the symptoms, the response to the typical treatment, and equally important, the recurrence of symptoms with subsequent ingestions, because some people come in and they think that they're allergic to X or Y or Z, and they say, yeah, but it only happens 1 in 4 times when I eat that food. So that is not consistent with someone having a true food allergy. And then diagnostic tests, measurements of specific food IgE, can only be interpreted really within the proper clinical context of the history. Otherwise, we're going to get very confused. So a detailed history should be obtained in every patient who presents with suspected food allergy prior to consideration for diagnostic testing. One of the things that I've started doing, we moved to electronic medical records, our group, probably a decade or more ago now. And initially I wasn't doing this, but I really would encourage you to do this. So move the history forward in your electronic medical records. So by that I mean if you do your HPI, that's going to change every time the patient comes in. If you do your summary at the end, your CPOE, that may have some components that may be repeated, but is going to change. But usually there is a section in your EMR that stays unless you add to it. In our EMR, that's a past medical history. And so what I've started to do is either copy or add to the past medical history something that's going to move forward really what initially happened. Because even in my own patients, I may be following them for 10 years, and they have a positive test of peanut, and then tell me again what happened when he was age 1, and it's totally what I had forgotten, was the initial clinical response. And especially when patients go from allergist to allergist within a group or even change who they're seeing totally, if you don't have that initial history, you just get falsely lulled into a positive skin or in vitro test. So, for example, in your past medical history, you can easily write age 1.5, ate peanut butter, hives, vomiting, skin testing at age 1.5, positive to peanut, almonds, cashews, no clinical history of ever eating almonds and cashews. Down the road, that can be incredibly useful when you decide whether you're going to do an oral challenge or not. Or another situation that we see all the time, atopic dermatitis, skin test positive for egg, peanut, sesame seed, blah, 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 never ingested. And then you can put in there, as you do elimination and reintroduction, what the results are, and that will move forward. It is so useful when you see the patient in a year or 2 years or 3 years. So a pitch for EMR being useful. So, but we see false positive tests in other areas as well in allergies and venom. Long-term observations of individuals with positive venom skin tests without a history of having a reaction revealed that these folks with positive skin tests long-term, if they're stung, only 17% have a systemic reaction to subsequent stings. And even in patients who have a history, who come in with a history of systemic reaction to insect sting, who have positive skin tests, you say, gee, they're all going to react. Well, if you take them into the hospital and sting them with what they're allergic to, only 60 to 70% will have a reaction. So another example of false positive test, even in a history of a positive reaction. We see this in aeroallergy as well, so it's not just confined to food allergy. There are a number of patients who will come into your office and they'll be complaining of food allergies. They've got irritation of mouth and GI symptoms when they eat certain pitted fruits. And you talk to them and they have no history of allergic rhinitis or conjunctivitis in spring season. You test them and of course you know what they're going to show, tree pollen sensitivity, but they have zero symptoms of allergic rhinoconjunctivitis. So we see this over and over. It's not confined to the food issue. So food sensitization and allergies are higher in infants than adults. We all know that. They do have, kids have a more immature mucosal gut barrier and immune response, and therefore a larger percentage of ingested foods seem to be absorbed intact, which is believed to account, at least in one reason, for the increased incidence in food allergies in kids. Also, the loss of skin barrier in kids who have atopic dermatitis provide a portal of sensitization to food allergies in the environment, and is also increasingly considered a route of food allergy sensitization that may evade oral tolerance. So in infants at higher risk of developing food allergy, can we intervene to reduce the risk of allergies developing, what is called primary prevention? And for those who are young in the audience, you won't know that 2 decades ago, the recommendations by expert panels in the United States for kids who are at high risk for developing food allergies, that you kept high-risk foods out of their diet until, for peanuts, age 3. My kids who are of that decade when this was recommended never touched or saw peanuts for the first 3 years of their lives because those were the recommendations at that time. The following decade, the recommendations got changed, and it basically said, we don't know, we have no recommendations, do what you want. Because with the recommendations of keeping high-risk foods out of the diet, the incidence of peanut allergy increased, didn't decrease, and some retrospective studies that I think many of you are aware of showed that Ashkenazi Jews in the United Kingdom who were told to keep peanut out of their diet for the first 3 years of life had 10-fold higher rates of peanut allergy compared to Ashkenazi Jews living in Israel who were fed bamba, which contains peanut butter, daily. And so then our current recommendations, as we now all know, unless you're not going to any allergy meetings or reading anything, is that we're supposed to add these foods into the diet as soon as feasible. And again, I want to spend a minute to talk about the LEAP study and the recommendations that came out finally after the LEAP study that is a little bit different than what the LEAP study showed. And I think it's important for everyone to know the difference. So again, as a review, the LEAP study took 640 infants who were considered high risk for developing peanut allergy based on their moderate to severe eczema or history of egg allergy or both. And they were between 4 and 11 months of age at randomization. And 500 of the 30 infants initially had a totally negative skin test to peanut when they were tested. And the prevalence of peanut allergy was 13.7% in the avoidance group at 5 years of age versus 1.9% in the consumption group. So a dramatic reduction by introducing peanut. There were 98 participants who had a mildly positive skin test at the time of initially being seen between 4 and 11 months of age. And that was defined as a wheal of 1 to 4 millimeters. They had an incremental peanut oral challenge, and if they passed that, then they were randomized. And the avoidance group had, again, a much higher incidence of peanut allergy at age 5 compared to the consumption group. So the early introduction of peanuts decreased the frequency of peanut allergy among children at high risk and modulated that immune response, which could have gone either way. And this is just showing you that data. The initial skin test negative cohort is group A, intention to treat. The middle is the 98 that had 1 to 4 millimeters of skin test reactivity initially, and then both groups combined the data. Now, the most recent recommendations are a little bit different than what the LEAP study showed. And so I'm going to put on my readers.
There's a pointer on the
Okay. Yeah. Okay. So instead of 0 millimeters, the recommendations were for kids who came in initially and had a 0 to 2 millimeter skin test wheal, that they were at very low risk of having any issues, and that you could either at home or in your office, depending on the preference of the allergist and mainly the preference of the family, give them a 2 grams of peanut challenge. If they pass that, which almost all of them do with a 0 to 2 millimeter wheal, then you instruct them to feed their kids 2 grams of peanut protein 3 times a week or more. So again, a little different in terms of 0 versus 0 to 2. And then the middle group, 3 to 7 millimeters, again, significantly different than what the LEAP study itself showed, which was 1 to 4 millimeters. It was recommended that these kids are getting close, but are not yet at the point of having true food allergy, and it would be reasonable to do an incremental peanut food challenge in these folks in your office or in a high-risk food challenge setting, where you would start low, increase, do a total of 3.9 grams of peanut protein. The top dose should be 2 grams of peanut protein with observation. If they pass that, then again, instructions to eat 2 grams of peanut protein 3 times a week or more. And then those in the last group who had 8 millimeters skin test size at the time they initially saw you, between 4 and 11 months, cat's out of the bag, everything's done. Now you have to wait for natural tolerance to hopefully develop or modify that system. Now, why were these recommendations a little different than the LEAP study? So the addendum by the expert panel used LEAP study data, but they reanalyzed the data, and they also used data from the Australian Health Nuts study. And so what this all told the expert panel is that data from the LEAP study, the rate of positive oral challenges at baseline for infants with 3 to 4 millimeters diameter skin test was higher than in infants who had a skin test size initially of 0 to 2 millimeters wheal. Only 3 out of 301 infants who were challenged had any reactions, and all of those 3 had mild symptoms, so they said, let's just sort of give folks 2 grams of peanut protein up to 2 millimeters. Infants with larger wheals greater than 4 millimeters were not included in the LEAP study, And so no safety data was available from this group from this particular study. However, when they looked at the data from the Australian Health Nut study, and they conducted peanut oral food challenges in a large number of slightly older kids, they were now 12 to 18 months of age. In the general Australian population, the rates of reactions was substantially higher with increasing skin test wheel diameter. So in the Australian Health Nut study, if you had an 8 millimeter or greater skin test size, then you definitely had a 95% chance of having a positive oral challenge. And therefore, for category B, the recommendations were for 3 to 7 millimeters, consider an incremental oral challenge. So some people may feel a little uncomfortable, going over 4 millimeters in their office. Other people don't feel uncomfortable. We do have a high-risk food challenge clinic that's at Children's if you're uncomfortable with the sort of, let's say, 5, 6, 7 millimeter to send them to. So natural history, so if we can't prevent it, what's sort of the natural history of kids developing clinical tolerance as they age? And that certainly does happen as kids, quote, outgrow their food allergy or natural tolerance develops. Generally, it was considered with egg and dairy that 80 to 85% of kids would eventually outgrow that food allergy, although data from Bob Wood's group said that for dairy it may be much lower, it may be 50 to 60%, and it may be that some of the earlier studies that said 85% of kids with cow milk may have been looking at non-IgE mediated kids, some kids with FPI. Obviously, they're going to all outgrow their issues. With tree nuts, 15%, fish, 10 to 15%. And with peanut, the data that's still quoted probably the most is 20% will naturally outgrow their peanut allergy. It's interesting, there is a small number of kids with peanut allergy who may outgrow it, but if they don't eat that food when they outgrow it, about 10% will return. So the peanut allergy gets outgrown, but then returns. So it's important, I think, in your patients who have passed a peanut oral challenge, who have had a clinical history in the past for at least the next year, to have them carry an epinephrine injector and ask them to eat peanuts regularly. I had one child was sort of fascinating, had a clinical history of peanut allergy, followed this gal over time, skin test size went to very, very low, so we decided to do an oral peanut challenge. The child passed it with instructions to eat peanuts at least 3 times a week or more at home, which mom says she did religiously. And 4 months later, she started to notice that when she had her peanuts, she was starting to develop an itchy mouth again. And then on the 3rd occasion, after the itchy mouth started, she developed generalized hives after eating her peanut. We brought this child back in. Skin test now is a whopping positive again. We took peanut out of the diet for 1 more year. Came back in. Skin test was negative. Passed an oral challenge to peanut, and subsequently has been eating peanut without any problem. So you can go back and forth on this fence of true allergy or not.
Did you have a virus at the time?
No, this happened.
Like a GI illness. You know how sometimes kids will have like a GI illness and it throws off their...
history of that.
Yeah.
So
I'll just interject that I've had 2 infants. They were both 3, 4 millimeters past the leap, and that's exactly what clinically happened. Is they both, during enterovirus season, got a bug, and then they started reacting.
Yeah.
Rash not just here, all over. And I said, stop.
I know.
Came back. The skin tests were about 8 or 9 millimeters, and I said, come back in 3 months. It was down to 4 again. Re-leaped them.
Yeah.
Even though it was the second.
Yeah, you definitely. There are things that can affect how obviously our body's immune response happens acutely or for a period of time. Again, it's important to know that for most of these folks, this is true, natural tolerance, which seems to convert lifelong tolerance for most of them, while attempts to increase food tolerance using immunotherapy approaches have predominantly resulted in desensitization and a return of reactivity if you cease taking that food on a daily basis. Okay, so incredibly important to know about the history and then the detection of IgE antibodies either through skin or in vitro testing. But as we know, there's a high rate of false positive with either of those tests. There is absolutely no indication to permanently remove a food from the diet based solely on a positive either in vitro or skin test without a history of a reaction. I see so many folks who unfortunately come in with in vitro tests from primary care folks who, many of them are mildly positive and have been told to eliminate 10, 15 foods that they had been clinically eating without any issues. And now we're just back to square one, and it gets pretty messed up. So you don't want to take a food out of a diet just because you've done a test with no clinical history. It's just wrong. The best, way to tell if someone is truly allergic is it the history or an oral challenge. If a food does not cause symptoms upon ingestion, there is almost never an indication to perform a food allergy skin test. So again, one of the things that I will do, here's a child who has egg allergy and tree nut allergy. And in the history, we know this child eats peanuts. We know this child eats sesame seed. We know this child eats almonds. I'm not going to skin test them. In fact, I'm going to write on the skin test sheet eats. So that's going to tell me, that's going to tell the family when they get that skin test sheet back. It reinforces that they're not allergic, that they should continue to eat. And most importantly, it tells the next allergist who may be seeing this child when I'm not there or in lieu of me that we don't need to test for this food because they're eating it. And if otherwise, we go down the slippery path of just positive skin tests without any history. And the history here tells you that this child eats it without any problems. Okay, so given that many folks have false positive tests, how do we correctly diagnose true food allergy versus false positive tests? So allergists first need to, one, acknowledge that many times the only way to tell is by doing an oral food challenge. Two, decide what is a proper time to do an oral food challenge. Know how to properly do an oral food challenge. Okay, so you have to be willing to do them. And if you know that there's an extremely high probability or an extremely low probability of any food allergy, you may not need to do it, although you may need to do it to convince the family that there really is not a food allergy. Some allergists avoid performing oral food challenges because of the risks that are legitimate of time, the risk of a reaction, and the lack of reimbursement, although it's important to do. So we have this sort of dilemma. Passing a oral food challenge has tremendous positive benefits, emotional impact on the family, anxiety, social isolation issues, healthcare costs, recurrent office visits, and the cost of these epi injectors. And for those wishing to participate in careers in the military, not having that diagnosis can be life-changing. There was a survey done by practicing allergists, done by the Quad AI. Jackie Kondrasik sort of headed this using SurveyMonkey in 2009. And it was reported that in training, only 45% of fellows had participated in oral food challenges during their training. The majority of practicing allergists in 2009 said they did do oral food challenges, 85%, which I think is probably what we saw here, although 14.5% said they did not typically perform office-based oral food challenges. And I think our fellows here have gone through one or more than one, right? Oral food challenges, would you say? Yeah, good, great. So in this survey, obviously it's a team that does the oral food challenges that involves the allergist as well as nurse or medical assistant. And the average duration, it takes about 3 to 4 hours to properly perform an oral food challenge. And I would say most of mine end up being between about 3 to 3.5 hours when we're sort of from start to finish. In response, if you receive reimbursement from third-party payers, do you think it's adequate? And, this is probably true for most things we do. Most people said, I don't think it's adequate for what I did. But despite that, 98% of the allergists in the survey felt that there was a need to perform oral food challenges. So again, the issues were what we talked about. For those in this area, this is about for 120 minutes what different insurance companies reimburse us for oral food challenges. And for the time and the risk and the labor it takes, it's pretty low. And it can be lower for some than others. But that's what it is.
And you can't bill an E&M code when you do
That's
an oral
correct.
food
It's
challenge.
bundled when you do an oral food challenge. It's a bundled code.
Unless they react under 2 hours.
Yes, if you react, then you change your coding. And in addition, you can add on time. So this is for the initial 120 minutes. If it takes you 3 hours, then you get to bill for another 60 minutes. Okay, so the oral food challenge timing is important to properly diagnose folks who have a true versus a false food allergy. If a patient recently experienced an acute severe reaction to a food and has this both combination and has a positive skin test or markedly elevated in vitro test, oral food challenge is probably not necessary. You should follow those people longitudinally. If, on the other hand, a patient has a chronic allergic condition such as atopic dermatitis or some GI issues, and skin tests are, either in the mildly positive range or unclear response after elimination and reintroduction diet, one or many oral food challenges may be necessary. And it's also important to confirm if you think that child has lost their food allergy natural tolerance, to confirm that with an oral food challenge. If a reaction has occurred in the recent past, in the last year, as you come in and take the history, what's gone on in the last year, have you had any inadvertent exposures, has anything happened? So if someone says, I ate peanuts and I broke out in hives, I went to the emergency room, I had difficulty breathing, obviously an oral challenge is not indicated, and I would say probably skin testing and that person's not even indicated for that year. They've already done their oral challenge. If, on the other hand, the skin tests show ongoing allergy, if there has been some accidental exposure without any reaction, then that would sort of sway me, no matter what the skin tests showed, to potentially consider and offer an oral challenge to that individual and family. I've had kids with peanut skin tests of 15 to 20 millimeters, and they have an accidental exposure to a small amount and do fine. And I've challenged them, and they continue with the positive skin test of 15 to 20 millimeters, and now are eating peanuts just fine. So again, the size does not necessarily tell you what's going on. The oral challenge in context of the history really is critical. So if you're trying to follow a patient who has a history of a reaction and a positive skin test or in vitro test, how do you sort of determine over time when it's potentially reasonable to do an oral food challenge? So some allergists will follow serial skin testing. I tend to do that, and I'll share with you in a little bit, I think, data that says why that may be a little bit more useful than in vitro tests, but other people follow in vitro tests, including Bob Wood, the author of this review article. Some follow both. They'll do skin tests and in vitro tests all the time, which I think in young kids is not necessary and not helpful. Some alternate between skin tests and in vitro tests. I think that's a little schizophrenic personally. And I think, you stick with one that you're comfortable with. You get to understand the parameters when you're comfortable doing oral challenges. And that's my personal preference. But you can do it a lot of different ways. So obviously trying to determine if a food allergy has resolved over time, you follow the skin or in vitro tests. The history of the ingestion with or without a reaction is the most valuable information you can ascertain in your history in the intervening time period since it last been seen. And whatever happens, put in that past medical history. You can add it to that because that's going to move forward in your EMR. If the patient has clearly reacted in the past or failed an oral food challenge, and again, you're following these numbers over time. If there's not been any reaction and you have these positive tests, then the paradigm is totally different, and you're going to be doing more and more food challenges to see if this individual truly is allergic.
Mike, just a couple slides back.
Yeah.
I think were they supposed to be flipped around? It's a little early in the morning, so I'm not sure if I caught that. One more slide back, I think.
One more.
The next one after that, actually. No, forward two slides, sorry. Where it talks about small exposure and oral challenge usually would not be necessary. Would that be, you would do the challenge, you wouldn't do the challenge if there was an accidental exposure without a reaction, especially
so you would. So I think what I'm saying is if someone came in and said, yeah, we've been staying away from peanuts, and Johnny or Mary had some food that we found out had a tiny bit of peanut in it, and they seem to be okay.
Right.
Then you'd say, okay, well, is that enough food to really say it's okay? Let's do a formal oral food challenge with a true serving to make sure that they're okay. Does that make sense?
Right.
Yeah.
Yeah.
If I wrote it wrong, then...
Yeah, just want to clarify.
Yeah. Okay. All right, where were we? Okay. Okay, so... Again, not to beat a dead horse. Incremental feeding, starting with a small amount with a time interval in between, marching on up. At the end of the challenge, you want to wait for 90 to 120 minutes after the last challenge. Have them observed in the office, make sure there's no issues. And it's also important to ensure that a full portion of the food was ingested to reduce any risk of not giving them enough food for the oral challenge. So generally these are safe, but they need to be conducted in a physician's office where resuscitation equipment and observational skills and medications are immediately available. And again, they have to wait for a significant period of time after the last food ingestion was given. And you have to ascertain if there are any symptoms very quickly to see if there are any symptoms that are consistent with IgE-mediated reactions, and if so, treat the individuals. Negative challenges are very useful and demonstrate, significant reassurance to the family and the patients, and hopefully they go on and change their lifestyles and are able to eat those foods. In doing a lot of oral food challenges, I've had one that went sort of bad, and I needed to call 911 to get help. And in retrospect, maybe I should not have done that challenge because the child was sort of on the autistic spectrum, and I think we were missing some signs, early signs, that the child was having some symptoms, but was fairly nonverbal. And so you can keep giving, foods until objective symptoms are there. It was sort of funny because when I called the mom the next day to follow up and find out how the child was doing, she said, "Oh, he's doing great. When can we do that challenge again?"
When I'm retired.
Yeah, when I'm not here.
Leslie will be seeing you next week. But on the other hand, so that's one, and all the others, you treat them, they get better, and it's no problem. But there are some people who are unwilling to do an oral food challenge in a patient who may or may not have actually an allergy to that particular food, who are more than comfortable injecting into their patients subcutaneously things they know they're allergic to. And so, if you're not prepared to treat reactions, you shouldn't be an allergist. So I've had to call 911 for subcutaneous immunotherapy reactions in my career more times than I've ever had to for an incremental oral food challenge. So okay. So you shouldn't do oral food challenges if people are not stable. That's the bottom line. So you have to be at your normal baseline. And what I tell folks when they schedule an oral food challenge, if you're having a respiratory infection or illness or symptoms, if you're having an outbreak of any cutaneous symptoms, call because we're going to reschedule the challenge, because if you come in, I'm going to cancel the challenge. So we just don't want them coming in without normal baseline. The question as to whether you tell your patients to take or stop oral antihistamines is a debate even in our group. If you're doing them for clinical studies, they absolutely have to be off oral antihistamines because we may block some of the early symptoms that you want to be aware of. On the other hand, I have some patients who, in addition to questionable food allergies, have severe dermatographic urticaria. If you tell them to stop oral antihistamines for 72 hours, they're breaking out in hives, and you can't ever do an oral challenge. Or they're so rhinitic that they're sneezing and coughing and stuff. If you stop their antihistamine, and you can't do an oral challenge because they're not at baseline. So that's an individual decision that you can make. So the skin test or the 5 in vitro test can reliably never predict the severity of future reactions, but the increasing number on the skin test or the in vitro test can tell you likelihood of something happening. There are very few foods where you have a 95% positive predictive value. You do with some young kids with a history. Again, this is a positive history and skin test size, as is mentioned there. But again, the problem is there is a high level of false positives. Let me skip this. So you do have some, data that you can rely on. There are these curves for pretty much all foods based on in vitro tests as well as skin tests. This is for in vitro. If you look at IgE levels for peanuts, and then on the left-hand side, the probability of reacting, so you can get a sense of, you want to tell the parents or the individual, this is our risk, are you willing to take that, and then have a discussion whether both people feel comfortable doing an oral food challenge based on the risk of the particular level. Same thing here is true for skin tests. For the top line, you can see what the skin test size is for egg, for dairy. It's pretty flat for wheat and for soy. And I want to spend a little time talking about one particular study that I think is very illuminating for peanuts. So this study was done where they looked at the positive and negative predictive value of skin tests for peanuts performed in those who all underwent the peanut challenge. So 140 peanut challenges. Of those 140, 18 were positive, except in very rare cases in this particular study, children who had a very convincing history of an allergic reaction and a positive skin test of 5 millimeters or greater were not challenged. There were 2 families that insisted on being challenged. One did not believe that their kid could ever be allergic to peanut, and they said, unless you do the challenge, I'm going to feed my kid peanuts. So they went ahead and did the challenge, and another family just was also unconvinced. So they had a strong history and a strong positive test, and they were challenged. But when you look at the data, the negative predictive value of a negative skin test was very good in this particular study, 100%. Unfortunately, the positive predictive value was 28% of a positive skin test. So they broke these kids out into 3 categories: suggestive history, acute symptoms in the setting of eating the particular food that all of us would consider a true allergic reaction. Questionable history, atypical for an IgE-mediated reaction, the type of the symptoms, the timing of the symptoms, the persistence of, I think I'm allergic to shrimp. I ate it, and I had hives that day, and I've had hives for every day for the next 2 weeks. It must be the shrimp, sort of thing. So questionable history. Negative history, no history at all, but the parents were concerned. The child has a tree nut allergy, but the skin testing is positive for peanuts. They've never had peanuts before, so negative history. never exposed, concerns about sibling who had an allergy, and so that was that category. So if you look at these 140 challenges, and you can see the suggestive history, the questionable history, negative history, and never exposed, and you go down to those who had a negative skin test and were challenged, everyone passed that oral food challenge. If you look at the suggestive history, 2 out of the 4 were positive, and then questionable, negative, and never exposed, and the rates of positive challenges goes down, and is the minority of individuals. Now, if we
But
break...
interesting, the never exposed actually had 5 positive challenges. Doesn't consistently go down. That's an outlier.
Well, it's still the minority, but with a positive skin test and never exposed, we don't have any history, and that could be some of our elite kids, right?
Yeah.
So they come in for the first time and they've got a 9mm. Well, they're probably going to react.
Mike, they talk about the spectrum of reactivity. In other words, some of these positives, that they react with a quarter teaspoon of peanut butter, and the others almost made it through the whole challenge.
Not in this study.
I'm just curious.
Yeah, no, they didn't break that out. But what they did break out, and I thought this was very interesting. So here, this shows you the size of the skin test wheel and the history on the left-hand side. Every circle that's open is an oral challenge that was passed. Every circle that is colored in is an oral challenge that was positive and failed. So everyone who had a positive challenge, again, this is one study, had a skin test size of 5mm or larger. There were 9 of 17 patients who had an extremely large positive skin test, i.e. 10mm or larger, who had a totally negative oral food challenge. So again, the history is so critical to put in context with the skin test size. And again, and I'm sure others who do a lot of oral food challenges that can sort of, remember kids that they challenged that passed with, again, large skin test sizes. Only 4 patients with a suggestive history had a positive skin test, and a positive skin test had a peanut challenge. Those that had 4mm or less had no issues despite their positive history, and then the 2 that had 5mm or larger with a suggestive history did react, and we talked a little bit about those. So I think if your skin test sizes are pretty small, even in a suggestive history, it wouldn't be unreasonable. If your skin test size in a suggestive history is large, I think I'd say you don't need to do an oral challenge. Anyone who has a questionable history, a negative history, never been exposed, depending on the skin test size, you might consider challenging. Can children tolerate egg or dairy in baked form? This comes up pretty frequently in our egg and dairy allergic kids. Often they can tolerate baked and foods before they can tolerate the natural raw food. So an oral challenge in baked form can help confirm that. We give recipes for our kids with egg allergy with a recipe for baked egg as well as for dairy. And certainly it's useful if they pass it to liberalize the diet further, and there's also some evidence that as you start to ingest baked food, it may enhance the ultimate loss of the food allergy for the natural food. We have skin tests and in vitro tests that sort of tell us what the predicted probability of reacting or passing, and so I'll have a discussion with my patients. If we have, let's say, a egg allergic kid who has a 5mm skin test size, I'll say, Johnny and Mary has a 80% chance of passing a baked egg challenge. Would you like to do it? If we have, 15mm, well, there's a 40% chance of passing the baked egg allergy challenge. Would you like to do it? And we sort of have that discussion. Similarly, the same sort of baked milk graph is here, whether you follow in vitro or skin test size. You can have that discussion. Tremendously liberating if they can eat that product in the baked form. Whether it really helps to enhance the loss, or these kids were already going to lose it and they're just on the process of losing it initially with the baked form is unknown. One study I want to spend a second talking about, and then I think we'll be done. So the study came out published by Dunn, Galvin et al. That sort of said, we know that we have all these issues with false positive. We've come up with a algorithm which they call the Cork-Southampton calculator, which makes predicting whether someone's going to pass or fail an oral challenge much better. So they developed this algorithm, they tweaked it once they looked at retrospective data, and then they did a prospective study that said, yeah, this thing looks really good. And they used 6 clinical factors. They looked at the skin test, the serum-specific IgE, the total IgE minus the serum-specific IgE, symptoms, sex, and age. And then they generated a calculator range that they considered 0, no allergy, to 1 allergy, which corresponded to a 0 to 100% chance of positive and negative outcome. And this Cork-Southampton calculator showed an advantage over other parameters that were used. So let me spend a minute looking at this here with you. So if you try and predict based on your in vitro IgE testing, looking at peanut, here you're 61% accurate. If you use the skin test for peanut to predict whether they're going to pass or not an oral food challenge, it goes up a little bit to 75%. If you add both of those, you gain a little bit, up to 81%, not that much. And if you use the Cork-Southampton algorithm, it goes up to 93% accurate in predicting. Very similarly, in egg, again, the serum IgE was inferior in predicting to the skin test. And adding the serum IgE to the skin test didn't add anything, but this Cork-Southampton algorithm did better. And exactly the same thing with the milk. The skin test was better than the serum IgE, and adding the serum IgE to the skin test didn't really do a whole lot. And the Southampton Cork algorithm was best. I read this article 3 times, and they kept talking about this algorithm, and I said, there's nothing in this article about what they're doing. And then the 4th time I read it, I saw that there was appendix, and here's where they had their algorithm. And the guy is a statistician, and he came up with this calculator, and it's totally incoherent to me, and it's patent pending.
I thought you were going to say you had to buy the app for $50.
Exactly, yeah. So again, it will be intended to be a guide. They plan on doing more prospective studies, and hope that will help in clinical decision making.
The irony of it is all of these studies for years now have been making a calculation based on data, so you don't have to do the challenge. Either you know it's going to fail or you know it's going to be positive. And yet those have all failed really in achieving that end. You have to do the challenge in the end to know the answer.
Correct.
Yeah.
And also to prove to the family that you're not just plugging in some calculation and risking their kids' lives with that. So I'm not going to talk about component testing. We're obviously out of time. It's worth a separate talk. But when it came out, it was like, oh, this is the end-all and be-all. We're going to do component testing, and we're going to know if they're going to pass or not. And truthfully, it's a slightly helpful, but it is not the end-all and be-all. There's still false positives, and there's no one specific number that is correct for every age, for every nationality, for every group. And you think, oh, they're all ARA H8 and nothing for anything else, and that's great. Or if they're all ARA H2 and nothing for ARA H8, that's terrific. But often you don't get that. You get some ARA H8, you get some ARA H2, and so it's not as clear-cut as we like. So I think in sake of time, I'm going to leave the last few slides, but they really are the crux of the talk. Do a challenge based on the chance of success, the potential of the risk, and the patient and the family has to share in that discussion, and how comfortable are they with risk. So an oral food challenge is a challenge, and you might say, I think we're going to pass, but I can't say for sure. Or you can say there's 50-50 chance, do you want to do it? And the patient and the family has to be involved in that decision. And it's also important in terms of the food that you're talking about. I mean, if you have to keep dairy out of your diet indefinitely, that's a pretty big hit for a lot of folks. But also there are cultural issues. You might have families that are vegetarian, and keeping peanuts and nuts and lentils out of their diet is incredibly difficult, challenging, and culturally very, hard. And you might do oral challenges for those folks more frequently or earlier based on family preference. This last slide really, just spend a little time looking at it, because this is the crux of the talk. When to do an oral challenge at initial diagnosis. If there's acute reaction and a strongly positive skin test, you do not need to do it. You follow those folks over time. If there's an acute reaction with a negative skin test or a minimally positive skin test, you might want to go ahead and do an oral challenge. If you have chronic symptoms, atopic dermatitis, etc., and you have positive skin tests, try elimination and reintroduction diets. You may have to do that once, twice, 3, 4 times till the family is convinced that the eczema is worse or not with the reintroduction of the food. And if still unclear, then you might consider an oral food challenge in that person who's never had an acute reaction but has a chronic condition. And then on the flip side, if someone has a clear-cut history and a positive skin test, you follow them over time. And as they get older, even if their chance is maybe only 30% of passing, before they go off to college, it might be worth taking that chance with that individual based on a discussion with the family and the patient. You'd never, ever, ever want to do an oral food challenge in someone who says, I don't care what happens here, I'm not eating that food. And that does happen. You might have someone who says, I'm allergic to peanuts, I'm staying away from peanuts, I don't care what the oral food challenge says, even if I pass it, I'm staying away from peanuts. Don't do it. It's just not worth it, basically. So it's a very complicated discussion with the family and the patient based on some of these parameters. So, yeah.
But a family member has a history of significant food allergy. The other family member has eczema with a huge positive skin test and an IgE of 20,000, but no history of systemic reaction at all.
Yeah.
Do you talk them out of a food challenge, or?
Well, that individual, like you, I'd probably treat the eczema with what we could, and then I'd say, why don't we try that food out of the diet for 2-3 weeks, and then reintroduce it. And sometimes, your answer is right there. My eczema got so much worse as soon as I brought that food back into the diet. There's no need to do, I don't think, a food challenge at that time. If you have this, I can't tell, then I do think it's worth doing.
The ones I struggle with are the ones that won't put the food in because they're afraid of the reaction.
Of eczema?
Yeah, they're afraid they're going to have an anaphylaxis just because their tests are so high. Usually come in with tests from somebody else's office and say, what are you going to do for me?
Have they been eating that food or not?
No, they're usually off it altogether, and then you're trying to figure out what do you do with these
people. If they haven't ever eaten the food and they have eczema, then I think you're sort of stuck. And the younger the kid, the more difficult, because, as you know, if you've done enough challenges with the lead kids, you're working with veterinary medicine, just what clinical symptoms you see. Do they have hives? Do they start coughing? Do they have rashes? You can't ask them, how's your mouth feel? Does your tummy hurt? Sort of stuff. So with the older kids, that's great because you can ask each time. But with the nonverbal kids, I feel a little more uncomfortable. But, the LEAP study is somewhat, helpful in terms of the skin test size. If it's pretty minimal, then I'm going to challenge them. If you have never eaten the food, huge skin test, nonverbal, I might wait till they're older.
You raised another dilemma. I'm sorry, Mike. why do some kids get eczema from food allergy, and why do other people have anaphylaxis? That's as much as a conundrum as why.
No, don't give me that talk next year. Well, you know, when Hugh Sampson started doing what he started doing 35, 40 years ago, his whole idea, there was this feeling that eczema could be caused by food allergy. And he was out to prove that it was not. That was his hypothesis. This is bogus, this is ridiculous. Eczema is not caused by food allergy. And so what he ended up making a career is that he realized that some kids with eczema it was, and his career took off in food allergy. Right. So, yeah, it's hard to know why a clinical response, why the people with tree pollen allergy develop only oral allergy syndrome and no allergic rhinitis or conjunctivitis. It's an enigma wrapped in mystery.
You should put in a plug for Tillis and Petroni, who are doing the peanut desensitization trials.
I think that was last week.
Yeah, I know, but just
here's a plug. They
reinforce that. Having peanut allergy can be dealt with.
Yeah. But I will say, and to be truthful here, Mike, the desensitization studies for the right person is wonderful, but it is for the majority of folks who succeed, desensitization and not tolerance.
Right.
And there's for a minority, and we don't know what that percentage is yet because the studies still need to go on longer, maybe 20% develop ultimate tolerance. So it's different having natural tolerance where you can eat or not eat the food based on your whim versus have to eat that food every day, otherwise you're going to lose your desensitization. It's a different thing.
And that's where the parents are a big part of the equation. Like parent A is like, no way, I'm not going to deal with that every day.
Right.
But parent B is like, it'd be great to know he's not going to accidentally eat 8 peanuts.
Yeah.
And the kid, as they get older, too, and are off to college, are they going to be eating that peanut every day?
Right. No, exactly.
Well, last week we got, I thought, an interesting comparison. Dan gave some very enthusiastic data for the value of studies that we're doing, especially the patch study. And Lisa gave much more realistic data that it's not as successful as we want it to be.
I think to Mike's point, I'd say probably nearly a quarter of the challenges we've done at Children's, which are relatively higher risk, are high school seniors.
Right.
It's like the parents like, oh God, what's going to happen when you go off to college? And almost all of them have passed.
The skin test size may be huge, but the history tells you what's going to happen.
All right, well, that was excellent.
All right, that was very good.
There's no answer to the question.
Not yet.
I always had this other feeling that there's salivary enzymes that digest some of the proteins. And so some people will digest enough of the protein in their mouth that it's not going to be an issue. And you do a spit challenge. You have them spit in a cup, mix the food in their spit, and see if that is skin test positive.
Was that a dream, or is that data?
That was a dream. No, someone needs to do that study.
Well,
a spit
right.
study. You fellows here?
You got all kinds of time now.
That's right.
So somebody asked you yesterday in Redmond,
So who have had reactions? So if you have a systemic reaction to venom and your skin tests positive, in Europe, that's not sufficient to get started on venom shots. They'll bring you into the hospital and they'll challenge you, and if you then have a reaction, then they'll put you on shots. In the U.S., we say the history and a positive skin test is enough to put you on venom shots. And venom shots were great.
I have to go up
But then the question is, how long do you stay on the venom desensitization shot? So it's at least 5 years, and then based on the individual's history, was it a really bad reaction? Based on what they like to do, are they outside all the time, gardening, hiking? Do they have underlying other issues like cardiac issues that if they have an anaphylactic reaction, it might be more devastating than if they didn't. Will depend whether you keep that individual on indefinitely or stop after 5 years. If